Yeah, good morning, everyone, and you are welcome. Before I start, my name is Yinka Oladele, and I will be moderating today. Just so you know, this program is going to be live streamed on our social media. I would like to briefly talk about the Oladele Foundation and the African Cancer Support Group. Sabiola, could you share it on Facebook, please? About the African Cancer Support Group. Why do we have the African Cancer Support Group? It is to support and help cancer survivors and patients to cope with their emotional traumas that is caused by cancer disease. And our aim is to help survivors, support survivors, and caregivers to share their stories, symptoms, information, and coping strategies. Our group is a safe place to share information, to share coping skills, and most importantly, is a place to give and get emotional support. For those going through one journey or the other through cancer, being a support group encourages healing and can help everyone develop a new skills. And also to relate to others and help survivors and patients and caregivers cope with emotional trauma that is caused by disease. Also, some important information to know: all lines will be muted, and the presentation is live and will be recorded and made available on our website. An email will be sent out to all registrants with the link when it is available. A survey will be made available before the end of today, and please let us know how you feel about today's event. If you have questions for the presenters or for any of us, please enter your question into the chat at the bottom of your screen, and the presenter will address them. Our able host, Mrs. Abiola Olatono, will actually will capture all the questions and project them on the screen. Our foundation does not provide medical advice. So for medical treatment, consult your doctor and medical team about your specific situation before embarking on health program. So how do we serve? We provide education and awareness, just as we are providing today. We have complementary therapies where we have physiotherapy, massage, acupuncture that we offer to our members. We offer mental health support, emotional support. We provide coping skills, health coaching, health and wellness support. We also have our material supports. We offer meals to families during treatments. We offer house cleaning and other things that we do for our members. Today, before we start, we would like two people to share their experience about their cancer journey before we actually invite our speaker to speak. The first person will be Mr. Levi Omara, who will tell us his experience with pain. Today we are talking about pain. And we know that pain is not, it can affect anyone. And nearly 8 million Canadians have lived with chronic pain. And the people who experience chronic pain face a wide range of physical, emotional, and social challenges. So today, the pain we are talking about is not just about cancer. Pain can affect anyone. So it is my pleasure to invite Dr. Omara to briefly tell us his experience with pain. Dr. Omara, please.
Yes, my name is Levi Omara. Are you hearing me?
Yes, sir.
Yes, my name is Levo Mara. I was first diagnosed with prostate cancer in the year 2002. At that time, I didn't have any pain at all. The only thing that I noticed was erectile dysfunction. Then I went to my doctor, and he sent me to the lab to diagnose it. And the lab gave me a PSA4. My pain came after I was given seeding. I was seeded with iodine in 2003, in December 2003, and my PSA was 7.5 at that time. So of course, the prostate was swollen, painful. When you go to urinate, urine was uncontrolled. So I had to carry some extra diapers, extra underwears to work, but I was able to work. So mine was totally different from others. But those who wait until their PSA is over 1,000, those are the ones who experience a lot of pain. If you catch this disease early, it's treatable, and the pain is minimal. You suffer from pain of the treatment itself. Because if they seed you, then the prostate is enlarged. Become uncomfortable during urination, you're having pain. Well, that's all I have to say. But those who wait until their PSA is over 1,000, of course, they collapse and they are unable to breathe. When they are put on chemotherapy, it's not better. There's some immunotherapy. That one is there, but it's expensive. So I have no experience with it. It's better to treat this condition earlier. Right now I have pain in my joints, which I cannot explain. They did it in my knees. I cannot explain that pain. They did the bone density, everything is normal, but I'm having pain. That's all I have to say about pain. But pain-related to prostate cancer, I have very little experience because my cancer was treated early.
Thank you, Dr. O'Mara. Thank you very much.
Yes.
And our second person that will talk about his pain is Mr. Bayo Oladele. He is a multiple myeloma survivor. Mr. Adebayo Oladele, please.
Good morning, and everyone. My name is Bayo Oladele. I am a multiple myeloma cancer survivor. I just want to start from where Dr. Levy stopped. His experience shows that if our if our condition is diagnosed early and treated early, the pain we're going to be experiencing will be minimal. And so I'm starting by saying that my myeloma was at stage 2 when it was diagnosed. Myeloma actually has 3 stages. I was between stage 2 and 3. It was so severe, so it was not diagnosed early, even though I've always been going to the doctor complaining about all these sicknesses for years, and yet it wasn't diagnosed. So my myeloma could affect people differently. What do I mean? 2 people with myeloma will have different symptoms. My own affected my spine and essentially my skeletal structure. And so by the time it was discovered, my spine was badly affected, a lot of lesions all over my spine. And so that's where my pain started. So my pain is totally different from Dr. Umara's pain. And today, as I'm talking to you, I'm still in pain. It has been a very long journey with pain medication, pain treatments, going from one doctor to another. All my veins and everything was tested. I make sure that, okay, the pain is not associated or with the vein. The muscles were tested. I've gone through, excuse me, I've gone through different labs within this city, trying to figure out what could be done. Because I went through stem cell transplant, which, as we all know, is the flushing of the blood and replacing it with a cleaner and better blood of myself. But nothing could be done with the bone. There is no way you could, anyway, nothing could be done with the bone. So while the blood was cleansed, my bones still remain as it was. Today, I have pain all over. It could be my hand today and my leg tomorrow, my back the next day. So it's all over the place. It is not an easy experience. The Tombeka Cancer Center has chronic pain section. I've seen several doctors in there. Currently, I've been referred to the AHS chronic pain group, I don't know, or department, whatever it's called. And it takes a while to get into that particular group. My referral was sent in over a year ago. I got their letter and they said again, it's going to take another year before I could get any prescription. What am I saying in essence is that it is very important for us to make sure we check ourselves. When you check yourself and all these stupid diseases, the cancer is detected early, we will probably be spared of, this chronic pain. Just like Dr. Levy said, it is very, very important for us to check ourselves so that our situation can be detected early. If my myeloma were to be stage 1 or stage 0, when it was detected, probably my bone wouldn't be damaged that much, and then I won't be feeling the pain today. Our speaker today is one of my doctors, one of my physiotherapists. I see so many of them. They're doing what they could, but the pain still remains. So please try to check yourself on time. If you are a man, do your prostate check on time. Do your colorectal test on time. Anyone that has screening, make sure you participate in the screening process. If you're a lady, do your breast cancer screening on time. Do your ovarian screening on time. It's very, very important. That is why we are doing what we are doing. Thank you so much.
Thank you, Mr. Oladile. It's actually my husband, so I can relate to the pain because I kind of saw it firsthand. It's not a palatable something at all. So like I said, today we are talking about pain. Pain, the myth, the reality, and the evidence. And our guest speaker today is Oluseni Olutayo. Sheni graduated from the University of Lagos in Nigeria with a Bachelor of Science in Physiotherapy and a clinical doctorate, that's DPT, from the Evidence Motion Health Professional Institute in the USA. He has been actively in physiotherapy practice for over 20 years and has been very diligent in keeping up to date with current treatments, trends, and techniques. He held licensure to practice in Canada, United Kingdom, Ireland, and Nigeria. Oluseni is very passionate about his patients, and constantly seeks creates ways to assist them in their recovery and meeting their health-related goals. He works as a clinical lead in AHS and a clinical director at Horton Park Physiotherapy. He is an outdoor person and loves bike riding, swimming, and traveling with family. Currently, he is learning downhill ski and game hunting. He is married to his high school sweetheart, and they have lovely son Joshua and a beautiful daughter, Alexandra. It is my pleasure to invite our guest speaker, Oluseni Olutayo, to the podium, please. Thank you.
Thank you very much. Good morning, everybody. And thanks for the introduction. When you were talking about my hobbies, downhill skiing, and I was looking at chronic pain, I said, oh my God, I hope I'm not setting myself up because downhill skiing is it's a high risk sport, right? But it's just, I mean, it's my attempt at being Canadian. I'll say that. I'm going to share my slide now with everybody. Okay, I hope I'm sharing the right screen. Just can you confirm that? The right screen?
Yes.
Excellent. Thank you. Okay, so today we're talking of chronic pain, the myth, the reality, and the evidence. Before I start, I would just like to re-echo what Mrs. Oladele spoke about, that this is not a medical advice. It is not meant to be your substitute for seeing your doctor or seeing your physiotherapist. The goal of this is education, right? And to make you seek for help at the right places so you can actually know how to direct your resources. That's our goal here. And I have intentionally taken, I've got a lot of images in this presentation intentionally, and they were picked intentionally for each slide, and I'll explain them to you. So again, my name is Oluseni Olutayo. Everybody calls me Sheni. I'm a physiotherapist with Horton Park Physiotherapy in Southwest Calgary. You would notice the word salad on the screen there that talks about that, emphasizes chronic pain. However, chronic pain never stands on its own, right? There are lots of synonyms around it. And you can even, if you listen very well to the testimonies that we heard just before now, you would notice a lot of things around chronic pain. It is never experienced in isolation. It's experienced with family and friends, right? There's always that sickness, there's treatment, there's healthcare. There are lots of words that are synonyms to chronic pain. Okay. Great. So the objective of this presentation actually is to create an understanding of what pain is and the different types of pain as it relates to us as just the people on the street. Understand the stereotype pain patient. What do we see with these people? The misgivings that we may have of them and the assumptions that even they may have of themselves, right? And how do I find help for myself? Where is that help coming from? The evidences in the medical management of pain, and also just a single slide of where to get help in Alberta, right? For those that are living in Alberta, because that's where I am. So to help you direct to where you can get help. And I like just what Mr. Oladele said, that I've had my referral now for over a year, and I'm waiting for 1 year before I get it. But there are faster solutions to that 2-year wait, right? Now you would notice my pictures here. The reason why we have that lady there with a red brain is because that's the real source of where chronic pain is, right? That's what we're going to be talking about mostly, the brain. It's what's going on there, right? The pain is at the joint, the pain is at the knee, it's at the ankle, it's at different places, but what's going on up there? That's our engine house. That's what we're talking about today. So let's start with a simple definition. What is pain? So pain is an unpleasant sensation, an emotional experience, usually caused by tissue damage. It allows the body to react to and prevent further damage. So really, pain is our friend. Pain is good. Pain is protective because that's what it's designed for. People will feel pain when a signal travels through their nerve fibers to the brain for interpretation, and it tells us that something is wrong, right? I would use Dr. Levy's testimony as an example for this. He said, my first diagnosis, I had no pain. There was no problem. It was caught early and there was nothing, right? Because the brain had seen it and was saying, well, something was going to happen. Tissue damage wasn't much, right? So that was how his brain interpreted it. Now, there are different types of pain and different ways to qualify pain. This is where it becomes a little complex now, right? You might check some books and you'll see, oh, there are 4 types of pain, right? That's the nociceptive pain, inflammatory pain, neuropathic pain, or functional pain. Some will further make it a little easier and say, okay, there are just 3 types. We've got the nociplastic, the nociceptive, and the neuropathic, right? But to bring it down to a base level, right? The classification is simple 2, and that's acute and chronic. And what really differentiates this, right? There are many differences in them, mind you, but what's the core difference in these 2 pain is time, right? Time becomes a differentiator between a chronic pain and the acute pain. So pain that resolves reasonably quickly is referred to as acute pain. It means that there's tissue damage, there is something external causing that pain, or even internal causing the pain. However, it's resolved rather quickly, right? There's a debate on when we say quickly, what does that mean? Because it's it's a vague word saying quickly, right? So the key, the difference is the time when we say acute pain is when the pain resolves between 3 and 6 months, right? That's all acute pain, and it's resolved and it's gone. However, if this pain lasts a long time, longer than 6 months, is considered chronic or persistent pain. And this is very common, like we're noticing that chronic and persistent pain becomes very common. So for this presentation, we're going to use between 3 and 6 months as our barrier between acute pain and chronic pain. And again, there are further differences between acute and chronic pain, right? And I just put a few of them here. Acute pain, like we said, is caused by something happening, so it comes suddenly, right? I hit my leg on a chair, I stumbled while in the park, or I fell down. It's suddenly, and it happens, right? It comes suddenly. It's usually as a result of injury, surgery, or something similar to these, right? And again, it lasts 6 months or less. It's relieved when the cause of the threat is treated. The injury is treated, the pain is all gone, and life becomes normal. For chronic pain, right, it always comes gradually, right? It grows on you. It comes very slowly and it builds up, right? It's usually as a result of conditions that are difficult to treat or even diagnose, right? And I'm sure people that are here that have experiences with cancer will understand what I'm saying, that when it's hard to diagnose, right, it takes a while, then the pain grows on you. Like I said initially also, it lasts more than 6 months. And it's difficult to find a lasting relief. And that's why we're really here today, that lasting relief. How do I find a lasting relief there? So we'll understand that chronic pain is one of the most underrated healthcare problems in the world today. It is not a Canadian problem. It's not an African problem. It's an international problem. And it's exactly like what we see in this picture, like an iceberg. All the person tells you is, I have pain, I'm uncomfortable. But there's a huge package right under the water that no one can see. Chronic pain is pain that lasts over 6 months, and the pain can be there all the time, or it may come and go, right? So it might be persistent, or it might be intermittent. It comes, it goes at different levels, right? So you would notice now that there's a very, when we say the word chronic pain, it's capturing a huge number of conditions that may fall under this. It's not a simple thing of I cut my hand and that's it, right? It's huge because it encompasses long-standing pain. It encompasses pain that may come and go, intermittent, right? And well, when we get to stereotype, you understand that when we get there, when we talk of stereotype. Now, like I said, like I said initially, acute pain is seen as a useful survival mechanism that serves as a protective and a healing function, right? So acute pain, we should always see acute pain as a good thing. And this is what I communicate to most of my patients when they're in pain, right? It is sometimes good. It's good because it tells us that there's something wrong and you can heal. Chronic pain extends beyond the expected period of healing and can involve complex psychological and social factors. So we're delving more into chronic pain now, right? And I'd just like to share this cycle with us because this cycle gives us a true picture of how chronic pain develops, right? Like any cycle, really, you can start from anywhere, but let's start from where the pain is, right? So the patient or the person has pain, right? There's anxiety that the pain signals tissue harm or damage, right? The brain becomes more focused on that pain. And because the brain is focused on that pain, changes take place in the neural system that causes more pain. Again, remember, pain will cause the anxiety. And because you don't want more pain, you're going to try and limit your movement. And limiting your movement will cause further changes in the nervous system, which will result in more pain. And that vicious cycle goes on. And this is how the pain keeps growing. It grows to a point where at some point it becomes unbearable for the person. The initial pain stimulus may be gone, right? But the chronic pain cycle will take over the system. So the initial pain could have been, I'm walking and I'm taking a hike and a twig cut my ankle. I got snagged on my ankle by a twig, and that's my initial pain cycle, my initial pain stimulus. However, when the brain takes over and goes on overdrive, right, the twig might be healed, the scar might be totally gone, but the pain cycle will go on and just takes over the person's life. Now, in this scenario where the pain has actually moved way more than the symptom, a situation where the pain sufferer starts showing other symptoms beyond pain is what we'll call a chronic pain syndrome. And anybody working in the medical sector in Alberta actually will have experienced people in this scenario. The symptoms will include anxiety, irritability, joint pain and discomfort, sleep problem, fatigue, suicidal thoughts, and it goes on and on, right? Now, the statistics that is available tells us that about 25% of people with chronic pain will go on to have a chronic pain syndrome. And this is when people have symptoms beyond pain alone. Like I said, I've listed a few here, but it includes also depression, and this will interfere with their daily lives. every part of this symptom adds to the initial, so let me just go back here, adds to this initial cycle of anxiety and makes the pain worse, right? So the symptoms are there, they're growing. Now, this chronic pain syndrome is also associated with some medical conditions that actually end up with, that are very, very closely related to chronic pain. Examples of this could be fibromyalgia, shingles, diabetic neuropathy, peripheral neuropathy, spinal cord injury, or any pain associated to the spinal cord, stroke, radiculopathy, pelvic pain, migraine, osteoarthritis, rheumatoid arthritis, low back pain, motor vehicle or workplace accidents, sickle cell anemia, any form of autoimmune condition, and sometimes surgical trauma. All these conditions can lead and point towards a chronic pain syndrome. Again, pain, like I said, doesn't stand on its own. There are physical and psychological cycles of chronic pain, and it's very similar to that cycle we saw initially, the pain cycle. Now, again, pain is evoked from feeling of anger, anxiety, depression, and fear. Now, we should always see this as a cycle, right? And like any cycle of events, it has to be broken. Breaking it at any level will solve the problem. Okay, at any level, will stop the cycle. So a pain can be evoked from feeling of anger, anxiety, being depressed, or fear. And this will always result to negative emotions, and it deprives the person of contentment, right? And a lack of contentment can lead to depression. Depression, you see the way the cycle starts. Depression can lead to higher perception of pain. The more pain you feel, the less active you are likely, right? Now we're having a double cycle, because this, from the point of being less active, right, we go back into a double cycle there, right? And the weaker muscles and joints will make us more prone to more pain. A lack of activity, right, makes the person weaker. So it's a double cycle of pain, right? On the right side, on my right side, is a cycle of pain we spoke of initially. On the left side is a psychological cycle, and they all meet in the point whereby the person is actually drowning in their pain, right? And if you notice, with this pain cycle, right, the initial symptom or causation of the pain may be gone, might be totally out of place totally. So we have an understanding now of where our pain is coming from. We know that the pain is interpreted by our brain to protect us. However, when the symptoms is gone, right, we know that, well, and the pain persists, it becomes chronic, and there's so many things that could be associated with this chronic pain. Now let's talk about the myth of chronic pain. My friend tells me, I have chronic pain. How can you help me? Right? All I see is somebody in persistent pain. That's what I'm going to see. And that's what we all see. Someone that tells us that they're in pain all the time. I've got this headache all the time. My leg hurts, my back hurts all the time. However, under that what we don't see rather, is the aching pain, the fatigue, the irritability, the numbness, the pressure, sleeplessness, soreness, stabbing pain, stiffness, discomfort, depression, anxiety that this person is feeling. There's so many things that comes with it. And that's why I compared it to an iceberg, right? That what we see is Mr. X is in pain. What we don't see is a lot more. The clinical picture of the typical chronic pain patient is, studies show us that 20.4% of adults generally have chronic pain or have had chronic pain. And 7.4% of the adults that had chronic pain, right, they frequently have this in their lives, and it has affected and limited their life and work-related activity. Now, think about the population and think about what 7.4% could be. Chronic pain will occurrence increases with age, and it was actually highest among individuals aged 65 and above. When it comes to pain tolerance, right, it's found out that Caucasians adults actually have more, are more likely to have chronic pain, right, as compared to adults of African origin. So I'll just put percentage to this. There's a 23.6% chance for a Caucasian. There's a 19.3% chance for an African, an individual of African origin. So I'm being careful saying of African origin because it could be an African American, it could be an African Canadian, right? So it might be of African origin. Hispanic has 13%, and an Asian has 6.8% probabilities of having chronic pain. However, while I was doing this research, I just checked something just out of curiosity about pain tolerance. And I was kind of surprised that from the studies, the race that had the least pain tolerance were actually the Africans, right? So we scream more than everybody else. So it's a little interesting to note that. And also, chronic pain is more common with women than with men, right? The picture that the outside person sees of this chronic pain sufferer, especially when we're not family members, when we're outside looking at them, what we really see is a lazy person who doesn't want to work. He's a no-gooder. All his pain is in his head. He's just imagining it. He's a crazy person. And this person is obviously seeking for some government benefits and social support, right? And he doesn't want to contribute to the economy. That's what we see. And I'm actually happy because there's a big drive right now in Alberta Health Services at actually providing care with equity, right? And all looking at our biases, because we all have bias one way or the other. And this is a bias, right? That anybody that comes with chronic pain, there's a red flag already. This person is either seeking drugs or they're seeking you to give them some sort of benefits, right? And I'm happy because the leadership in Alberta is actually seeing that. Now, the assumption that the pain sufferer actually has of himself is that the initial source of my pain is still what is causing my pain. All right. What started this pain is what is still causing it. The injury I had, the surgery I had, that back surgery I had is still what's causing my pain, right? And really, that is not true. So all these are just biases and they are myths and really not true. But imagine a person living a life like this. It says living with chronic pain is like trying to get comfortable on a cactus sofa. So can we just, my daughter saw this picture and said, wow, she screamed, this doesn't look very comfortable at all. And really just looking at the picture, it's impossible to live a comfortable life on a chair like this. And this is what the pain sufferer might be going through. The myths are not true, and chronic pain patients are really suffering. So how do we help with chronic pain? How do we do pain management, right? Again, intentionally, there's some words here that we can play with. You can see analgesics, opioids, palliative care, quality of life, suffering. Now, all of these words actually are things we should think about when we're thinking of managing the pain. Quality of life, post-operative pain, opioids, analgesics, nursing care, pain relief. These are all things that we're thinking about with our pain management. And we'll start from the very, very basic. Where do we start? Okay, now, again, an intentional picture. This is the brain screaming, help, because all chronic pain is actually going on up there. Remember that acute pain is produced when tissue is damaged or there's a structural change to the body. All pain is produced from the brain, Acute pain is treated with medication, stay active, and some exercises, and gradually the pain will go and you'll get back to your normal life. However, when the pain continues, when the pain is continued to be produced and the pain goes beyond 3 to 6 months, this is considered chronic, and it initiates and indicates that the tissue damage may no longer be the source of the pain, but more with the brain being unable to shut down the pain production and the increased sensitivity of the nervous system. Right. So the brain, so I mean, in simple words, we'll say that the brain has gone on overdrive. The brain has produced pain for acute and I just stopped and just keeps, it's falling into that cycle and it's just on overdrive and it's going on. And the treatments cannot be simple. It cannot be a simple case of take medication or do exercises or ignore the pain. I mean, many years ago, during my undergrad, I remember that fibromyalgia then was considered that the clients were malingering, really, that they were not really in pain, because the evidence then was that, oh, they weren't in pain, it was more in their head, it was a psychological problem, right? So let's deal with it that way. But now we have more evidence that these are real pain. This is pain that is real. And the treatment is not simple. It has to be approached systematically. And I've gone through, I'm going to highlight 6 ways that we can actually touch the treatment. And this will be medication, surgery, thoughts and emotions, diet and lifestyle, a life story, and the physical activity and function. So we'll just pick each one at a time. The goal will be to retrain the brain. And this has to be intentional. And whoever wants to do this needs to seek professional help early. And it's a gradual and an active process. Now, being an active process, it means that whoever is involved needs to participate in it. It's not a case that somebody's going to do it for me, whereby like my mom will help me do this, or the physiotherapist will do this for me. No, the person has to be involved on their own and do these things for themselves. So like I said, it has to be a systematic approach. So let's start with this. Full disclosure, I am not a medical doctor. I cannot prescribe medication. I will not tell you the medication to take or not to take. But all we know is this: medication can help and should be slowly weaned off with time. A few years before COVID, there was an opioid prescription guideline that was rolled out in Alberta that described that the opioids were being prescribed too much for clients and they were getting addicted. And the guidelines actually, just to summarize it, advised and recommended that physicians should seek alternate methods of pain relief rather than opioids. That should be their first port of call. But eventually they could go to opioids, but again, the opioids should be tapered and weaned off. Because as much as these medications will help, well, their side effects actually could be bad. So your family doctor will provide you with the appropriate medication. Now, the goal of the medication will be to help, but not let me see. Yeah, will be to help, but the goal will also be to get going with the other processes, right? That can eventually help retrain the pain and the brain. Some will actually tell you, how about surgery? Now, with surgery, the successes are limited, and you should always get second opinion and consider all the facts before progressing with surgery. Again, I'm not a surgeon, so I would not advise you to or not to do that. However, get second opinion and consider all the facts they're telling you and read all the fine print. Now, other methods of relieving pain, right, that could get you going with the other processes could be acupuncture, physiotherapy, pain treatments, dry needling, right? If you approach a physiotherapist, they will give you a lot of options of managing your pain after an assessment has been done. Emotional well-being. This is another approach that we could do, or we should do rather, right? Because again, we know that from the pain cycle, the emotions actually had a lot of had a role to play in that cycle, right? So our thoughts and emotions become important. The moods, stress level, emotions, and other psychological factors uh, um, will learn to reduce this and wind down the emotional and stress level. Examples of how this could be done, right? And funny enough, in African culture, right, we've got things in place of this that actually could help us. Simple things like having a quiet time for meditation, self-reflection, prayer, healthy social structure, family relationships, a good social structure, avoiding toxic situations. Things like this actually promote our emotional health. And again, my image just shows the brain in different emotions, right? So I'll just start from the first one. It talks about enjoying life, being happy, good sleep time, sleep well, meditation, be active, right? The next person, check your health early, right? Watch your emotions, what you're doing, stay active, play, right? I'm going to ignore this last person with the twisty eyes, right? Uh, again, be adventurous. We all have ideas. Let us pursue our life dreams, right? Let's question things. Let's love. Have good relationships out there, right? Make ourselves vulnerable. All these actually make us more emotionally well, right? It improves our emotional well-being, and this is a good starting point for recovery. Because remember the initial cycle we had, when the thoughts and the pressures are too much, it actually it stimulates our nervous system, which increases pain. So that's our first approach, emotional well-being. The second approach is our diet and lifestyle. Again, consider that the modern lifestyle and the harm it's associated with it, right? Right now, most of the food we eat are processed food, alcohol, imbibing in alcohol, smoking, the sedentary lifestyle. Now, these don't actually help us because these wear us down and actually breaks down our body. So, a diet and lifestyle, right, becomes important, and it's another good place to start recovery, and to be a good idea really to consider meeting a dietitian, a registered dietitian, or a nutritionist, depending on where you are, and actually meeting a lifestyle coach, right? Looking at the bad habits that you have, you know yourself, pick the bad habits, things that you know harm you. I'll give you a good example. There was a time in my life, actually, let's say about 15 years ago, I know that I would take um, at least 3 or 4 cans of pop a day. I was doing that for myself, right? But you see, and my excuse was that, oh yes, I was very active, so I was burning the sugar. But really, I knew the truth that I was harming myself, right? So those kind of habits that we know ourselves, that we know we are harming ourselves, we all know when we are not eating healthy, right? We know when we're doing that. So it's somewhere to start, but also seeking professional advice to even give us the substitute. So I like taking burgers all the time, right? But what's the substitute that I can still stay healthy and I can still stay fit? Okay, what's the substitute for that? So that's where the dietitian comes in and the nutritionist. They can actually give me a proper advice on where to step out. My pain and life story. Now, this is an opportunity to actually think deeper about the meaning of this pain and what it means to you. I would pick Mr. Oladele's example for this, right? So he said, in his own words, I was diagnosed, I had been seeing my doctor several times and nothing was done, nothing was seen, right? Until I got to a stage 2 before, and you could hear in his words that he's wondering, why wasn't this seen, right? If it was, and the question in his mind is, if it was seen, could it have been different? right? So that's an example of a life story, right? What was associated with this pain when it started? Is thinking about what were the events around my life when this pain was identified. Now, with a life story, PNE actually helps, and PNE is pain neuroscience education, right? This is an education strategy within the psychosocial model of care for individuals with pain-related musculoskeletal conditions, animations, and motions. It induces insight into the patient's complaint, improves coping with complaints, improves self-control, and induces, in some cases, peace of mind. It's an approach for us to know that looking at our lives, the emotions we had around the pain, right? It could be, I mean, the life story could happen like, how has this affected my work? When I started my pain, did I lose my job? How did that affect my finances? Am I still blaming the pain for my finances? Or am I blaming my job place for my pain, right? How has it affected my work? How has it affected my family? And also it lets us to recognize what it is and know where to start our emotional story from, right? So painting a picture, now PNE can be done with, now I know there's some physiotherapists that will do PNE with you, but also I know that Alberta Health Services in the pain clinic, actually that's part of the referral that you're talking about. That's one of their programs there, the pain neuroscience education. It's something that you can sit you down and you have a session with them. It tells you, you would explore your story yourself, right? What kind of habits did I have before this injury, right? How was my life then? Am I blaming myself or am I blaming those habits? Am I actually blaming my spouse for this? That maybe because my spouse shouted at me that day, that's why I walked out and then I had the car accident, right? If she had not shouted at me, I wouldn't have had the car accident. So there's so much emotions to this, right? And it helps us, what it helps us do is to have a clean slate in our lives, start afresh, right? Know that these emotions is there, we deal with it, and we're able to start life afresh and live life. Physical activity. Now we also know that physical activity will always help. Staying active, right? Even when you're in the pain. So rather than saying do exercises all the time, we talk about pacing your activities and challenging yourself daily, right? You seek help definitely from a professional, a physiotherapist, right? Pace your activities to your tolerance, challenge yourself, get back to life, enjoy your life, right? Return to normal or a new normal. Returning to normal or a new normal is important, right? Activity pacing and titrating your activities becomes, and what that really means is that, I'll just give an example. Rather than cleaning my whole condo, I live in a 2-bedroom condo, rather than cleaning my whole condo in one day, I can choose to clean just one room on Monday. I clean room 2 on Tuesday. I clean my TV in my front room on day 3, right? I pace myself so that I've got enough time, energy to enjoy other aspects of life. Rather than doing the least important things in the morning, I do my most important things first, things that are must. And when it comes to things that are less important, I postpone them to the afternoons or to the evenings, right? So these can actually support and help the way we see, the way we enjoy and actually recover slowly. Enjoying relationships, right? Build relationships, build friendships, enjoy the ones we have, make new ones, right? And actually, it's not enough to have a friend. You need to enjoy your friends, spend time together, go out sometimes, right? Share with them, make yourself vulnerable, right? Things like that actually help us not only being active, but also helps us emotionally. And now this is my own bias. Enjoy the outdoors. Go out, get out of the house, do anything, just get out of the house. During the summer vacation, my son is 9 years old, my daughter is 4 years old. There are many days I just tell them to get to the backyard and I lock the door. They should go have fun somewhere. Just play. Nobody's going to steal you, right? The park is close to my house. Just go out and do something. Nothing's going to happen. And if they steal you, we'll find you in Calgary. Calgary is not very big, right? Enjoy the outdoors, because nature heals us. God made us in nature, and it's meant to be a perfect cycle. So nature will heal us actually. You seeing the beauty of nature actually calms your brain, because the whole goal here is to get the brain to stop sending those signals, because initially those signals are gone. The initial source is gone. We're trying to solve and stop these signals. Now in Alberta, right, there's several programs in Alberta that could help, right? We've got the Healthy Living Program. And so I'm telling Mr. Ladili this is a program that the wait time is way less. In fact, since COVID, their wait times is almost close to zero, really, because they now have programs that you can do online. They do group programs and group counseling sessions for chronic pain. And the goal of the program includes the following services: patient education, disease-specific and general lifestyle topics, self-management and support through better choices, better health workshops, and supervised exercises. So I can tell you that the Healthy Living Program wait time is less, and your family physician could refer you to this. Also on the Alberta Health website, we could get, there's some self-help tips, right? I've just included the PDF here. So something that when we're sending out the presentation to people, anyone can check on that and use those resources. In Alberta, in Calgary also, we've got the Chronic Pain Clinic, which is at Richmond Road, right? And I just included the link to where and how you can get a referral to them there. Then also, most private physiotherapists in Calgary can support you as long as they're working collaboratively with your medical team, right? Because remember, if you noticed what we went through here, it's a team approach. It's never just the physiotherapist working. There's a dietitian working with you. There's the PNE experts working with you. There's the chronic pain specialist. There's your medical doctor who is actually going to head this team, right? So working collaboratively with other the team leads, other medical teams actually helps to support your recovery. And in conclusion, remember that chronic pain is produced from the brain, and the brain can be retrained. Thank you. And if you have questions.
Wow, thank you, my brother. Thank you so much. I'm going to start from the last, I think the last slide, where you talked about the resources that we have in Alberta. I know that chronic pain, the pain center, the one at Richmond, sometimes it takes a while, even years. Yeah. I know when my husband's pain got so, it was just too much, and it was referred. Probably because it was during COVID, they did not acknowledge it until 6 months after. And after the acknowledgement, they now said, oh, we will respond to you a year after. So you can imagine you are waiting even just to get a response for almost 2 years. And the patient is in pain. So what can you do?
So I'll give you a truth now. First of all, I don't work in the chronic pain center. I work with Alberta Health, and I understand what's going on in Alberta Health Services. The population of Calgary is 1.3 million. The statistics we have says about 7% of individuals, of adults, have chronic pain. So 7% of 1.3 million, right? And that's one at Richmond is a major chronic pain center, right? I think not just for Calgary, but I think for Southern Alberta.
Oh, I see.
The huge number of referrals that come in, it is gigantic, right? I would never want to work in that place because the work is too much. It's too much there, really, right? So really, and that's why you have a long wait time. Now, I'm now talking with my hat on as a team lead in Alberta Health Services. What a few of us have started doing in scenarios like this is building expertise within our teams, so that when people are coming to us first, Like if you're approaching, let's say Tom Baker now, in Tom Baker, we make sure that we have some sort of expertise within our team, so that rather than refer you out to the chronic pain center, we rather treat you in-house. But those are individual like individual remedies that we're kind of building within individual teams, right? But still, all those referrals are being funneled through that single clinic, and that's why you're having that long wait time. But because of this, right, that's why we have the Better Healthy Living program, whereby it's online. And it's a good place to start your program because they're going to start you off with some education, and it's online. So there's almost no wait list, really. I think they have regular days they do their programs, actually. Right. So if your doctor refers you there, they're going to send you a link to join their next meeting. Okay. So they're almost like counseling sessions. We're talking about general pain. You're hearing people's life stories, right? To see how pain. So just a start. Again, no medication there. They're giving you a start. They're giving you a start about how to stay active, how to pace yourself. They're in group programs. So they're not speaking to you specifically, they're speaking to the group, right? Sometimes they give opportunities whereby you've got questions, you can ask your questions. It's time bound and you can go to the next session again with them. So so I understand the chronic pain clinic, why it's long, but there are options where there are stop gaps where we can go there we'll go to the healthy living program first before you progress to that.
Okay, thank you. So the healthy living program, is it just for cancer patients or for everybody?
Sorry, I didn't hear you at all.
The Alberta Healthy Living Program, is it just for cancer patients or for everybody?
Everybody.
Okay. Okay, thank you. And we have some questions here. Now, this person says her fiance or his fiance has been having some pains in the right side of his hip. So it's a hip. Sometimes it moves from the hip to the lower right side of his back. We are looking for a chiropractor or any other suggestions that will help.
Okay, so now I'm going to speak as a biased person with this question, right? And I think, to be fair, I should be biased with this, right? More information and I should be biased with this. So just this, the description is vague, okay, but it sounds like a good place for a physiotherapist to assess you, right? Now, physiotherapists are, anyway, there are lots of physiotherapists in Alberta, in Calgary, around the world. But I've been wondering, there's a huge number of chiropractors in North America compared to other continents, right? I think the chiropractic is more of a North American concept, right? However, my bias, being a physiotherapist, is go see a physiotherapist, and I'm very sure they can actually assess, they can treat you. Because like I said, if the source of your pain is not being dealt with, then you can't even call it chronic pain. Your pain is still acute because the stressor is still there.
Thank you.
You're welcome.
And I'm sure the person that asked the question is actually in Calgary, and I will reach out to the person. I don't even know of it. Reach out to the person. Next question, please. So as a mental health therapist, I was wondering what advice or approach that you have that can help clients who are in therapy for mental health and also present with chronic pain. The person said, I've already picked a lot of strategies around cognitive and narrative therapy. Thank you.
And now this is the typical chronic pain patients, right? Because when you look at the whole life of the person, the life picture, they start looking like mental health clients, right? You see the young lady walking to your clinic telling you that, I'll use a true picture, like with no name. 23-year-old lady comes into the clinic that she's got back pain. And after a second treatment, she's kind of telling me to sign a form for permanent disability for her. And I'm wondering, you don't plan to work the rest of your life? She's 23. However, when you do further investigation and see through it, you notice that she's in chronic pain. And because she's not been treated appropriately, they've been treating her as, oh, well, just acute pain, we're doing physiotherapy, we're not looking at the multidisciplinary approach, right? And so she's getting frustrated. She's feeling that I can't go back to work anymore, right? We had a discussion with her, and well, by the time I discharged her, she was back to work, modified duties, which is good. So really, as a mental health therapist, I think that what I would advise is that's collaboration with other professionals, right? Not working in isolation, but seeking that, I mean, in your expertise, you're already doing the cognitive and narrative therapy, which is excellent, which is your expertise, right? However, the other things, find a nutritionist, think of a lifestyle coach for this person, right? Look for a physiotherapist to bring in, work as a team for this individual, right? And definitely our results will be better when we're not working in silos.
Thank you. Thank you. Any other question, please, everyone? Yeah, somebody just said working with other professionals is great, and that is true. So that we are not just working alone, right? And when you work with other professionals, you can work collaboratively, and it will be easier when working together. So if you are here and you would like to ask your question, you can unmute yourself, and please raise your hand so we can identify you. Please raise your hand if you would like to talk. We have a few minutes left.
There's one hand up.
Okay.
Yeah.
I can't see.
Yeah.
Let me just see.
You can just talk, Stabila.
Okay. Yeah, you can just talk, please.
Okay. Thank you so much, Shani, for this presentation. It's really awesome. I just want to make a comment that there was a couple of months early this year, I think around May, I was having a lot of pain, like neck pain, back pain. I've never had pain in my life like that. It was like, I'll just wake up, I'll be in a lot of pain, and I want to go to work and I won't be able to do anything, move. I'll take Advil and Tylenol at the same time before I even get into my car. So by the virtue of the fact that I have a lot of physiotherapists that surround me, so I'm always defaulting to someone like Shani. Shani is my physiotherapist. So I just called. I said, Shani, please come. I've taken Tylenol. I've seen my family physician, and my family physician is like, if you're not careful, you can move. If you are going through some things emotionally, you can actually transfer those emotional pain to physical pain. And I thought, he said, okay, be careful. Don't set yourself up for something like a muscle pain that results into fibromyalgia. So one of the things I did was like, I asked Shani to come and look at my environment. And he asked, where do you feel the pain most? And I said, usually when I enter my car, I'm in excruciating pain. So he actually looked at my posture, tried to help me set up just look at my environment to adapt how I am sitting down, if I'm actually arching too much, if my sitting position is okay, if my setting of my chair is okay. He went through all that with me. And I just want to say that after that, there was no pain, because I think it was the way I was positioning myself and the way I was actually structuring things around me, moving my computer desk at home. Even though I have the eye raising table, I wasn't using it effectively, but just allowing the physiotherapist in my space to be able to help me align things, help me to able to deal with the acute pain, so that I know that, because I thought I've had this pain for 3 months. Because I'm a healthcare person, I'm already thinking, oh my God, I have chronic pain. But to just confirm some of the things he's saying, sometimes we need to deal with the basic and take away. Sometimes it's not all medication, because I've actually taken Advil and Tylenol together every morning. There was a time for almost like 2 weeks. I was taking it like that. And I said, no, I don't want to live like this. So just a comment. Thank you.
Nice to hear that. So I should send my bill over then.
You did. You already billed me.
I know.
Yeah, thank you. Somebody is saying, oh, that's great, it goes to homes. Yes, we have a complementary therapist for our members. And also, Shani also does is it mobile physiotherapy? It's not really a commercial, but yeah, it does a home physiotherapy. And then we also have a home massage therapist. And does any other person have, 2 persons also raise hands? So please, the first person, let me just see. Samson Ikenga, please, Pastor, please ask your question.
Thank you, Bros, for the presentation. They are very informative. I think my question actually has to do with things like shoulder pain. I mean, when you, from your standpoint, you think you've done what you would do, but you just probably wake up in the morning and you still have those shoulder pains. What exactly could be attributed to this?
Okay, so persistent shoulder pain. It's hard to actually see something about that, but I'll just talk in general, right? If a joint aches persistently, right? I've got that pain over and over again, right? 2 things could be. It could be one, it's not really being managed. The source has not been, somebody, whoever is managing you or treating you really is treating the symptoms and not looking at the source. So a proper assessment, you may benefit from somebody assessing you properly, not just assessing your symptoms, saying that the shoulder is hurting, right? It will shock you that your physiotherapist will be looking at your neck when you're talking about your shoulder pain, right? Because that's looking at it holistically. So a physiotherapist might be doing that, looking at different parts of your body, even though your pain is at the neck. So that could be number one. It could be that oh yeah, you were not properly assessed, and so only the symptoms were being treated, not the source of your pain. That could be one. I can't really say for sure. Again, it could be that maybe the source of the pain has been dealt with really, and that person and you're slowly progressing towards chronic pain. However, to know if you're going towards chronic pain, you would find out that your pain will not be at the shoulder again. You're going to be saying my right shoulder, my neck, my low back, my bum. Even though your initial pain was the shoulder, it will be widespread. So really, it would be a very good idea if you saw a physiotherapist to assess you, right? I'm believing that you must have seen some physiotherapists, done some exercises, things like that. I must have seen your doctor with medication, if that's where everybody goes, first of all. But let someone else look for a second opinion. Let someone else do an assessment on you, right? And give you their take. What I tell folks is that during your assessment, if your PT or your medical professional is able to predict your symptoms, they're telling you that this is how you feel, that's how you feel, then you should know that they know what they're talking about. They're not guessing about it. It's something that they've seen over time. And just to correct Mrs. Oladili a little bit here, we do have a physical structure. Our clinic is at Southland in Calgary, and we offer mobile services for massage therapy and physiotherapy. While physiotherapy, we encourage more people to come into the clinic than mobile therapy. Yeah. So I think that answers, yeah, thank you.
Thank you so much. Got that.
Welcome,
thank you.
Yes,
we'll come and visit your physio for sure. See what that you have. Thanks.
We'll be expecting. Thank you.
We have another person that raised hands, Adebanjo. Do you still have question? Okay, now that I'm online, I have the mic. Let me see. I have my other friend here, Bayo Adeyoriju. It's actually is another physiotherapy. Before Bayo speaks, Dr. Matthew Ocholi, please unmute.
Okay, thank you, man. That was fast. I thought I would be on the queue. So thank you, Shani, for this discussion, this talk. So me, it's I don't know. I don't know if mine is chronic or if it's just pain. But mostly, I feel it sometimes when I sit down. Like yesterday evening, I sat down for some time. I stood up and it was like I couldn't really stand. I was almost, sometimes it pushes me to try to crawl. I mean, I start feeling like to do like that. it just happens for a few minutes and then gradually it will just dissipate, and then I'll start moving. So sometimes you see me moving, you won't even know I have any pain. And it's not that kind of pain where I'm, shouting, hey, this place is paining me, but I feel it. Sometimes it's even when I wake up from sleep, that's, it's like that initial moment when I will not, it's like I can't just move, or I'll move with so much effort. But if I start moving for some time, then I kind of forget that it's even there. So I really don't know. Like, I've tried to talk to my doctor, and they still cannot find, a situation, an answer for me. In fact, I even have another appointment coming up maybe next month. So what advice do you have for such things?
So it sounds like you're having pain when after sitting down or lying down for a prolonged time, then you start to move. That's what you just described, right? So I think if you do not manage it, you may progress to chronic pain, right? I don't think it's chronic pain right now because it's just on one spot. It's just that back. And according to what you said, when I start moving, it moves away. So there's so many indications to this that, well, we might be talking of a disc issue or a muscle issue around your lower back, right? But that's just word of hearing you without doing an assessment. So it's sounding like that's what it is. The funny thing about these issues is this, right? And I'm happy you brought out, I wanted to say this, but I skipped it in the presentation. My doctor has tried to help me and he couldn't do it. And that's because most doctors are trained to send you for images, right? The research is that images do not, most of the time, correlate with our symptoms. So the image may say that, during this, I wish I could present the paper. I'm sure the paper would see, but there are papers that would show that it's showing two different images. One image shows that the back is totally gone. The disc has been collapsed. The muscles are squashed up. But this person is walking normally with no symptoms. Whereas another image will show that there's a mild impingement here, but it's not much. And that patient is in agonizing pain. So images do not correlate with your symptoms. That's why sometimes it's hard for doctors to actually move forward from things like this, right? So again, I would almost like a default answer, really. You need a proper assessment by a qualified physiotherapist who knows what he's doing, knows what to look for, because first of all, I'm glad that everybody that's spoken here, you are able to identify your pain. You are talking about it, you know where it is, and by the time you have a good discussion with your physiotherapist, really, right, you would create, you are going to actually help him to be able to have a bias towards exactly where he should be going to, so that is not, because physiotherapists are trained not to be treating symptoms. Their training really is to be going to the source of this pain and dealing with it from the source, right? So that they might never touch you. Like in your case, it's the back, right? You might be shocked that what your physiotherapist may be treating may be, well, most likely it's going to be your back, really, because it's central there, right? But there are many ways to approach it. It could be needles, whatever, depending on what they see during an assessment. So I will encourage you that, yes, to avoid chronic pain, please see a good physiotherapist to assess you.
Thank you. Mr. Bayola, please.
Thank you so much, Mr. Olaseni. You've been a lot of help to me in so many ways, and really appreciate that. And of course, our Dr. Adeyoriju also has briefly been my physiotherapy, but I couldn't follow up. It wasn't his fault. So, Mr. Olaseni, I just wanted to, okay, so I just want to find out from you, right? When does when does one actually transition from, physical pain that can be identified and the symptoms still remains in there and it can be seen? When do such patient transition from, physical pain to head pain? I mean, to imagination or to psycho-related kind of pain? How do you define when that happens? Because, okay, I said at the beginning that a lot of lesions in my skeletal structure, those lesions are giving me pain every day because they didn't heal, they are still there. And my pain is not actually at joints. So the joints, nothing. Even when I'm having pain in my leg, you press it, you don't see anything from outside. How do you categorize such type of pain? How do you know that it is really pain? It's not your brain that is actually out of whack, that is already doing something wrong?
Oh, that's a very good question. Excellent one, right? And I'm going to attempt to answer that, right? Okay, so how do I know when my pain goes from my symptom to my head?
Yes.
Right. Yes, that's kind of the summary there. It's a hard question to answer because there's no definite answer that says this is what you're going to say. However, there's some things that I can start guessing around it, right? When I start considering my life story, when I start considering my emotions, I start looking at, first of all, the duration matters. Duration definitely matters, right? But also I'm looking at that big picture of the pain cycle, right? Has it affected my life more than just a pain, right? Has it affected my social structure? Has it affected my functioning? Right. It's that's why, first of all, it's important to know how much has it affected me more than if I just had a regular pain. Then I know that it is, I won't say it's my head, right? But I'm going to say that my brain has started, I'm moving away from symptoms that are peculiar to pain into other symptoms. I'm showing other symptoms. I'm showing depression. I'm showing some anxiety. When all those things start coming along, right, then we know that definitely this is no longer pain on its own. It's still pain, not pain on its own, but it's not becoming a chronic pain syndrome when there are other symptoms around it that are not typical of pain. Does that answer the question?
It does. Thank you so much. But I'm just using myself as an example here, really, because definitely pain itself, pain doesn't come by itself alone. It comes with, other symptoms, other signs, other effects on the body of the patient. Because if my leg is paining me, definitely it's going to be difficult for me to work on it.
Yes.
If I cannot work on it, or if I attempt to work on it, it could lead to something else. And if I cannot work on it, I don't know, after a long time, it may lead to some other issues in my body. So I really don't, I've been on my own journey for the past 6 years. And we are talking about 3 months to 6 months.
Mm-hmm.
I just don't know. So does it mean that the AHS chronic pain group department, they deliberately delay the time people will get to them so that maybe, it goes from very physical pain to head and maybe eventually it's going to go away? Are they intentionally delaying admission into their department?
No, I can. That's a simple answer. That's no. It's not intentional. Is the volume of referrals, and they're prioritizing really based on who's coming first and who's, that's really, and the resources that they have. But just to back to your initial question also, right? It's like pain is a difficult thing to say. It's difficult to think about, right? And I'm glad that you're quite open with this, right? So yes, 6 years for pain. Now, remember we said when the cause is gone, when the reason for this pain, what initially started this pain is gone, then we can start pointing it as chronic, right? In your case, because of the source of your pain, it is not totally gone. It's still the tissue damage. The tissue damage has not repaired, right? So tissue damage is there. It's not progressing, we thank God, but the tissue damage is there. So that cause is still as it is. So really, and that's the peculiarity of cancer pain, right? That's one of the triggers for anybody being assessed for cancer. They said if you have persistent pain and you have pain at nights, right? Pain that wakes you up at night and things like that, go for a cancer screen. That's the peculiarity with cancer, right? Because the tissue damage is done and it's not being fixed, right? So it's there, it's persistent. Right. So yes, it's cancer pain, but yes, it's chronic pain. When it comes to timeline, it's chronic pain. When it comes to its source, it's cancer pain, and that's why it's kind of mixed. It's mashed up all together, right? And but yes, that's methodology can actually help. It's not going to help to take away your pain. It's going to help to improve the quality of your life. Right. So sometimes, a good medical person will tell you that your pain is not going to be zero, right? Let's establish that fact. It's not going to be zero. If we're going to rate your pain, it's never going to be zero. But we're going to find a reasonable level. But what's more important than that pain is quality of life. How are you functioning? How are you associating? Are you socializing? Those are the things that becomes more important than the pain, so that we're slowly training that brain not to, the pain is there, yes, but not to focus on that pain, but focus on other things, on socializing, on the quality of life I'm living, on engaging, right? That's why the difference is there, if you understand it, right? So yes, and it's hard, but it's just how it's good. Diverting the brain, moving the brain away from focusing on that, and let's focus on something else.
Thank you so much.
Yes, you're welcome, sir.
Yeah, thank you. I said Bayo Adeyoriju was going to talk. Okay, my sister just said something here. She said, as the doctor said, emotions have a lot to do with it and overcoming it. It is what we refer to as the impact of your thought life. Dealing with emotions and understanding how to regulate emotions will be helpful. Thank you very much. Now, before Bayo comes on, I have one question here. We are now in the computer age. We all sit and look at the screen every day for hours and hours. And this gives us neck pain or back pain. Is there any exercise you can suggest that will help some of us that use computer a lot? And you can see now that most people are having a carpal tunnel on their wrist, yeah. Right? Yeah. So is there any exercise that can be done? Thank you.
So this question reminds me of a joke I had when I was in university. All the boys in my class used to encourage the girls to wear high heels, so that you can have back pain and we can have a job. So we told the girls, wear the high heel, your husband will pay, don't worry. Because eventually it's all those kind of, so the high heels, the goal of the high heel is it makes you look very nice and elegant. However, because it throws away your center of gravity, eventually it puts a lot of pressure in your lumbar spine and you're going to have back pain in the long run. So it was a joke we used to have then. Now to the computer age, it's good. It's good for business.
For the technology people.
Yeah. But however, the solution is this: you don't have to suffer back pain because of computer age. Really, setting up a good workstation should be your first approach. Most people that work from home now, and most people, when you come to me and you say I have back pain, I have shoulder stress, the first question I ask is, are you working on your dining table or are you working on the bed, on your sofa? Right? Because they're working at home. And that the answer is always yes. So setting up a good workstation to start with should be your first approach, not even the treatment. Just set yourself up with a good workstation, right? There are professionals in Calgary that will help you set that up if you need that. But it's important to get that set up first of all. However, you can't afford it, you don't have the resources to do that, right? And you have this pain. Another step to do is pacing yourself, taking frequent breaks on your system, right? Most IT workers, we actually, I saw a software in Fort McMurray a while ago whereby your system shuts down. Well, a screen comes over your system every hour, right?
Oh.
And just reminds you, yeah, take a break, go for a walk and come back and continue. When we say go for a walk, we're not talking of a hike, no. A simple walk to the washroom, taking like 20 steps and coming back and sitting at your spot and continue the walk might be good enough rest you want to do, right? But taking those frequent breaks is good. If that, again, is not helping you, then definitely you now need to see a professional to help teach you some proper posturing, right? Posture exercises to stretch some muscles, tighten some muscles. And even after the treatment, if you get the treatment and you go back to your bad habits, we're still back to where we started from. So after the treatment, you still have to get that good workstation, get those healthy habits going on. And I think the problem that nobody's talking about is the cell phone problem, right? And I'm going to tell folks now, if you have kids that have used cell phones for at least 3 to 4 years, look at their thumbs, right? You notice, go online and look at what a monkey's thumb is. Monkeys don't have thumbs, right? So I hope you can see my image here. You can see me. So the human thumb rolls forward a little bit. Okay, let me see. Yeah, there, good. The human thumb does this. Look at your kids that use cell phones a lot. Their thumb is this. This muscle here, the tena eminence, is very flat. And slowly the whole world is turning into monkey thumb because of cell phones, right? And they're all coming to the clinic with pains around their wrists, right? And their neck because of the phone, but it's actually, there's a physical evidence to what's happening to them, not just the pain. You can see what's happening to their thumb, right? It's actually where the muscles are wearing out there. Right? So yes, technology is actually affecting not the older population alone, but even the younger ones, right? And it's affecting the younger ones way more than the older ones, right? And it's something, it has to do with a lot of moderation and cutting it off. There's no point treating it. You can prevent it from happening. They're all preventable, right? Moderation, proper posture, proper habits, and we won't be needing much treatments, really.
Okay. Thank you.
You're welcome.
Thank you. Bayo Adeyori, please, as we close. You are muted.
Hello, everyone. Hi, Shani, and the host. Sorry, I didn't listen to most of the presentation. I'm actually logging in from work. So I plan on watching most of it after it's posted online. Yeah, I'm sure Shani would have done a good job with the issue of chronic pain. When I saw the title, I was quite interested. And I thought I could sneak in and listen to most of it, but yeah, I got a little distracted with patients. Yeah, this is an interesting topic because physiotherapists, that's what we do. We help people with different kind of pain, musculoskeletal pain and pain from neurological issues. There are different reasons and different causes of pain, which I believe the presenter would have addressed some of them. And if there's any specific questions, I can also join in to answer some of the questions, especially if you relate to orthopedic and musculoskeletal problems, which is where I work in private practice. Most of my patients are orthopedic related or joint pains and backs and necks and injuries, we deal with that. So if there's any question around there, I can always answer some of your questions.
I think we have to bring you and Shani back, two of you. We bring two forces back to talk about different skeletal problems that we have. Everybody, we all have pain. It doesn't matter what we do. We have people that drive trucks that are in their trucks for like hours and hours, maybe 15 hours on the go. We have people that are IT professionals that are sitting down all day. By the time they get up, it's like their backs are all kind of gone. We have people that their work is standing. Look at cashiers that work in different of these retail places. By the time they get home, all their legs and what have you are kind of sore. I just want to say thank you to Shani and to Bayo. I'm sure we'll still talk more about this because pain is not just for cancer patients. Pain affects everybody. Pain affects us from our head to toe. And like I said at the beginning, millions and millions of people go through pain every day. And sometimes it's all through our emotions. And if we are able to help ourselves, I think we'll be able to get out of it. So in closing, once I already said thank you anyway. So somebody was saying that my question is around weakness and discomfort in knees. Weakness and discomfort in knees. Aka, what kind of question is that? Can you unmute and ask your question?
Okay,
Please.
Thanks for the opportunity. I was hoping that I can speak to it. So this question is actually for me personally, and I'm in my 40s, and one of the things I've noticed is weakness in my knees. Like I used to do a lot of hiking, but it's something that I can do. Sometimes my knees stiffen out and the muscles around there stiffen out, which is very discomforting. And a lot of times when I'm just walking or bending my knees, it creaks. It keeps creaking like continuously and stuff. I'm just curious what could cause that, and what's the best way to manage it, because it gets sometimes painful, but I think it's more the discomfort or when the muscles tighten and I can't move. And I'm a woman, if my voice didn't make that clear. Seen a doctor and I've been told it's normal, walk more, but it's actually stopping me from doing the things I like, which ties into some of the comments around even your mental health and feeling down. Thank you.
Yeah, thanks for that question. And maybe should I let my big brother Bayo? Oh, you didn't. Oh, you didn't hear the question. Okay, don't worry. I'll take it. Take the question. No worries. Okay, so what you've described really, let's establish something to everybody here. Okay, pain is good, but living with pain is not normal. So if your doctor tells you that, oh, you're a woman, you're getting older, so it's okay to have some pain, it's normal. Pain is not normal. We were not designed to have pain. So let's establish that. Okay. Now, what you have just described here, right? My knees are clicking when I'm hiking. And I'm very sure it's when you're going up rather than when you're coming down. I've got that tightness on my thigh. Your pain and discomfort is mostly either in your knee or just above your patella. Am I correct? Can you, hello?
Yes, I muted, so I was trying to find the unmute button. Yes.
So your pain is either in the knee or above the patella, is clicking each time. I think what you're describing to any physiotherapist is giving me a bias to think that, she's got something called a patellofemoral syndrome. And again, like
in layman's language, please.
Yeah. So you said now without, and this is the physiotherapist training. I've not seen you, right? You're describing it, and it's sounding like something that I can see all my textbooks flipping in my head. It's more of patellofemoral, and it's actually caused more by the weakness of your thigh muscles, nothing to do with your knees. It might just be your thigh muscles that are weak, and we need to work on those thigh muscles to get them stronger so that it can actually help align. So really your thigh muscles, your quadriceps, might be where your physiotherapist should be working rather than just working on the pain that you have in your knee. So a good physiotherapist will work on the pain for you to have comfort, but they will also work at the source to strengthen those quads muscles so that it doesn't come back again. You've got good habits already. You sound like an active person. Those are good habits, right? But yes, the physiotherapist will look at that whole picture. And some might go the extra step at looking at your shoes also. That are those shoes right? Where is she throwing her weight, right? Because the sole of your shoes tell us a lot of story, right? Even say if the therapist telling you that, please come for your appointment with don't come with a new pair of shoes, come with something that you wear regularly, and they tell you to come in with your shoes, and they're looking at your shoes. They're not crazy. It's telling us a lot of story about where you're throwing your weight. Are you throwing it to the side? Are you throwing it inside? How is that affecting your knee? So yes, so you will need a physiotherapist. Your pain is not. Being a woman or a human being is not what you should be living with. And I don't think you have chronic pain, I'll be honest. I don't think
I don't think it's chronic either. It's just very uncomfortable because I'm at a point where even activities like hiking that I love, I'm not able to do it. Going up the stairs is becoming difficult, but I would not call it chronic pain. But when you talked about even mental health, feeling down, withdrawn, because I'm an outdoor person and I'm not able to be as active. I get it. Maybe it's not bad yet and hopefully never, but I get it. And it's interesting that a lot of times we don't make the connection on with discomfort, pain, our mood swings, etc.
So I mean, really, in conclusion, I would say see a physiotherapist who's and now, honestly, even if you don't come see me, whoever you see, tell him that there's one physiotherapist that told you that you might be having patellofemoral syndrome, and that would actually help whoever is seeing you to know what they're looking at, right? Because really, sometimes we need to help our health professionals so that they've got a million things in their heads, right? You can help them narrow it down and they know where they're looking at still. So yeah.
Okay. Wow, that's a good one. Thank you.
That's good. Thank you. It really gives me some comfort knowing where how I can approach it in the direction as opposed to it's okay. Just manage.
Yeah, thank you. As we round up, Ola, if you don't, I guess you have the last question. Please go ahead.
Hello, can you hear me?
Yes.
Okay. Thanks for having this session. I apologize, I joined rather late because I got the link late. My question is to either of the two professionals there. One of the things about posture and all that, especially in our digital world, is, the use of cell phones, and you have to hold your phones very close to your hair sometimes for a long time. And oftentimes people have, try to navigate that by having headphones and all that, but that also comes with its own issues of radiation and all that from the cell phones to your hair. What would you recommend as maybe there's a better brand, or is there another way we can do this? Because we're trying to run away from one issue of holding your phones close to your hair every time. And now you have your headphones on your head every time. Could there be dangers in that? And if there is, what are those? And what are your recommendations for managing that?
Okay, good. You can go, please. Yeah.
Well, I've heard, not a neurologist, but we've read a few articles. I haven't seen a lot of research studies about how radiation affects radiation from the phone, how it affects the brain. I've read a few things, but not really, have not explored what research communities are saying about that. So I can't really speak to that as much. But in terms of posture, these days, I think we usually just encourage people to use, you know, like Bluetooth and stuff to, so that you're not, you know, bending and putting the phone to your head. There are a lot of devices that you can use that will give you a better posture when you're doing work. I'm not sure if that answers your question.
Okay, thank you. Shani, any addition?
No, I mean, what I was going to say is I'm not an expert with when it comes to radiation or phone radiation. Really, honestly, I'm not an expert. What I recommend to people is exactly what Bayo said there. Just like what I'm wearing right now, headsets. Really, that's what I recommend. Really, and the whole goal is just physical posture. You're holding your phone, bending your back. But again, what I would also say is moderation. Let's always remember. I know that most people here, we're all very old people here. We're all in our, at least the youngest person will be in their 30s, so we're old already. We're not young at all. If you're above 30, you're old, right? Let's remember that phones are designed for making and breaking appointments, right? If we use it that way, for making and breaking appointments, not to be on the phone chatting with a friend for 2 hours. Let's go see people. Let's go outside and see people physically, right? And encourage our families to do that also, rather than always on the phone. Technology is good, but let's use it to moderation. That might actually be a good way to start. Yeah, thank you.
Yeah, thank you so much. Thank you so much. Somebody is commenting your chair.
Oh.
Yeah, thank you. And as we conclude, we just want to say thank you again to Shani and Bayo. Like I said, we're going to bring both of them back and to talk to us about a very good topic that will be useful and beneficial to the community. Well, once again, this program was brought to you by the African Cancer Support Group. You can find us at africancancer.ca. We support cancer survivors, cancer patients, and those going through challenges of life. A very big thank you to our tech host, Mrs. Abiola Olatono. The Oladele Foundation, through the African Cancer Support Group, we are a charitable organization, and we'll covet your donation because it will help us to bring support and more programs in the future. And we have tax receipts and is available for all donations. There are different ways you can donate. Second chance at oladele.ca, or you can go on our website, africancancer.ca, or you can send us a check, African Cancer Support Group, and our address is on the screen. Once again, and also we need your feedback. We have posted the survey on the chat. We'll also send it to all those that registered. If you did not register for this event, please put in your email address. And also, for those that work in corporate organization like Suncorp, we actually registered with Benevity. So Benevity, for those that register with Suncorp or any other corporate organization that uses Benevity for donation, we are also registered with them. And please, we need your donations to be able to continue to bring programs to the community. Once again, thank you so much, and we'll be expecting your response to the survey questions. Thank you, and have a good day.
Thank you. Bye-bye.
Thank you.
Thank you.
I'm serious about the chair.
Okay.
That headrest, I think I need it.